When managing a posterior polar cataract, it is crucial to differentiate it from a subcapsular cataract as the surgical approach and technique may vary. Misclassification could lead to increased complication during phacoemulsification. I will outline several critical considerations when dealing with this type of cataract. After performing the clear corneal incision, it is essential to ensure that the capsular rhexis diameter is between 5 and 5.5 mm. This is optimal size facilitates the implantation of the IOL in the sulcus in case of the posterior capsule has ruptured during emulsification of this type of cataract. Hydrodissection should generally be avoided to prevent complications. However, a gentle peripheral hydrodissection to separate the anterior capsule and equator from the cortex can be performed without completing the hydrodissection behind the nucleus. Additionally, hydrodelineation is a crucial step for separating the nucleus from the underlying cortex. During emulsification, this type of cataract, it's important to feed the phaco tip with the nuclear fragments, which enhance emulsification of this type of cataract, and also doing the viscodissection of the posterior epinucleus and the cortex can help facilitate the emulsification of this type of cataract. Maintaining the anterior chamber stability and preventing its collapse are mandatory during all the steps of emulsification of the posterior polar cataract, especially during the cortex removal, to prevent a sudden rupture of the posterior capsule and vitreous loss. That's why filling the anterior chamber with the OVD viscoelastic before removing the irrigation probe or the phaco probe out the anterior chamber is essential. As we can see now, I am filling the anterior chamber and the capsular bag with OVD before getting out the anterior chamber with the irrigation probe. Here is the end of cortex removal. Everything is good. Now it's the time for also filling the anterior chamber and the capsular bag before taking out the irrigation probe. Here is a single piece hydrophobic IOL, implanting inside the capsular bag, washing out the viscoelastic anterior and behind the IOL. As you can see a good overlapping of the capsular rhexis with the optic of the IOL. Then doing stromal hydration, and thank you for watching.